Hello, everyone. It is Dr. Nurse Tutor here. For those of you who are coming back, welcome. For those of you who have not had the opportunity to meet me, I am Dr. Nurse Tutor. My name is McFrancis George. I am a Med-Surg certified registered nurse with 15 years experience at the bedside. I also have a master's as a family nurse practitioner with 6 years experience in primary care. And I have a PhD in nursing education along with the postmasters in higher learning, higher education, and online teaching. I have two other videos available that are geared towards Nclex tutoring. This will be the third video where we will be reviewing questions, breaking down questions, understanding questions, the rationale behind the questions, as well as me teaching you how to critically think to process the answers to the question. Not only just to get the question correct, but to understand the rationale behind why the questions are correct. So if that is something that you are interested in, I provide free 30-minute tutorials twice a week, either Nclex based or AANP for my master's level students. I will provide these videos twice a week. Now, this will be the third video, so this will be the last video. And then I will kind of switch gears and go into tutoring for my AANP master's level nurses who are getting ready for their family nurse practitioner certification exams. So what I'll probably do is I'll do 3 Nclex videos, and then I'll do 3 AANP certification exam tutoring videos, and then I'll kind of flip-flop between the Nclex and the AANP, just so that both areas that are interested in tutoring will have the opportunity to see videos, and you don't have to wait a long time for you to see either AANP or Nclex certification videos. So once I do 3 of each, I'll just flip-flop between each certification exam just to give everyone an opportunity to have some studying and tutorial sessions with me. If you would like one-to-one sessions with me, please send an email to me at drnursetutor@gmail.com, and we can talk about the details then. But if you're just interested in the free tutorial videos, feel free to just come on and get a good experience, a different approach to tutoring, and hopefully my style of both auditory as well as visual teaching and tutoring will help you get a better grasp as to how to attack the questions on these certification exams. All right, so we're going to delve into the first question. The first question is, which of the following is not considered one of the 10 rights of medication administration? Now, there are 10 rights to medication administration that patients must know, must understand, and us as nurses must abide to, respect, and honor when taking care of patients and administering medications. So if you don't know what the 10 rights of medication administration are, I'm going to let you know what they are once we get into this question, but please take note of what these 10 rights are, because a question like this can and may show up on the Nclex exam. So it's very important not only to know it for the Nclex, but to also know it in practice. Okay, so the question is, which of the following is not considered one of the 10 rights of medication administration? And the options are: A says the right verification, B says the right to refuse, C says the right documentation, and D says the right client education. Now, the correct response is the right verification is not one of the 10 rights of medication administration. The verification of the doctor's order for a medication is to confirm the right patient, right medication dose, right route, and right time of frequency. Though it is important, verification is not one of the 10 rights of medication administration. Verification on the nurse's part is to make sure that you have the correct patient, the correct medication dose, the correct route, and the right time and frequency. That is extremely important as a nurse, but it's just not one of the 10 rights of medication administration. But that is something that you do have to make sure you know when you're about to administer medication to a patient. So this can actually be 2 different different questions on the Nclex. Why? The Nclex not only can ask you what the right of medication administration is, but the Nclex can also ask you as a nurse, when you're getting ready to administer medication to a patient, what do you have to make sure you know? You have to make sure that you have the correct patient. You have to make sure that the medication that you're administering is correct, the dose is correct, my words are fumbling. The dose is correct, the route is correct, and the frequency is correct. So though that's not the answer for this question, make sure that you know that if you do get a question that asks you about medication administration to a patient, what do you have to know before administering that medication to a patient? But in reference to this question, verification is not one of the 10 rights of medication administration. So I'm going to tell you what the 10 rights are. If you don't know, please write that down. Please make sure that you know that. So the 10 rights of medication administration are medication, dose, time of frequency, patient, route, client education, documentation, right to refuse, history and assessment, and evaluation. So please make sure that you document that and you know what the 10 rights of medication administration are. Okay? The next question is, the CRIES scale is used to do what? The CRIES scale. Another acronym that you are responsible for knowing as a nurse, and who this scale is important for, who this scale targets, what this scale is for, who this scale targets. The options are to assess motor functioning, to assess sensory functioning, to evaluate responses to a tactile stimulation, or to D, evaluate responses to pain analgesic. Assess motor functioning, assess sensory functioning, evaluate responses to a tactile stimulation, evaluate responses to a pain analgesic. If you do not know what the CRIES scale is, it's important to know what the CRIES scale is. The answer is actually D, evaluate response to a pain analgesic. The CRIES scale is used to evaluate the neonate's response to a pain analgesic. A neonate is a baby or a pediatric patient who cannot respond verbally to pain. This pain scale is also used to assess pain among, like I said, of course, pediatric patients who cannot express verbally their pain, either neonates or your pediatric patients who have a hard time expressing what their pain levels are. So it is an observational behavioral pain assessment scale for the pediatric population, and we use it among children less than the age of 3 years old. Some of these standardized pediatric pain scales, in addition to the CRIES scale, is you may be familiar with the FACES pain scale, the toddler preschool postoperative pain scale, which is also called, the acronym is TPPPS, the neonatal infant pain scale, which is NIPS, the Children's Hospital of Eastern Ontario pain scale, which is CHEOPS, the FACES leg activity cry consolability pain scale, FLACC, the visual analog scale, VASOBS, the observational of behavioral distress, OSBD, the comfort pain scale, and the pre-verbal early verbal pediatric pain scale, which is PEPPS, that is used with toddlers. In this instance, we need to know what CRIES is. CRIES is a pain scale that is used for neonates to visually see if they're having pain, because these patients are not able to verbalize. So the Nclex has the ability to ask any of these other ones, such as the FACES and the preschool postoperative pain scale, things of that. So if it would be wise to know what the different nonverbal pain scales are that are used with neonates or nonverbal patients, just so if something like that is thrown at you and they give you that name, in this instance, they use CRIES, right? But these other scales are also nonverbal scales that we use, or observational behavioral pain scales that we use to assess pain in nonverbal patients. So it's important to know what the different pain scales are and that they do assess pain. They do assess the pain, possible pain reactions in nonverbal patients. But motor functioning, sensory functioning, tactile stimulation, that's not what these scales are used for. So just familiarize yourself with these different pain scales and who these different pain scales target. So next question is, your client has been getting total parenteral nutrition for bowel rest for the last 4 days. During your assessment of your client today, your client is saying that their chest hurts, and you also assess the client and they're experiencing dyspnea, shortness of breath. What is most likely occurring with this client? So your patient has been getting TPN for the past 4 days. You go in to see your patient, and your patient said they're having chest pain along with shortness of breath, dyspnea. What is going on with your client? So we know that TPN is total parenteral nutrition. Usually patients who can't take food PO or are having some sort of issues with their bowels, whether it be bowel obstruction or anything going on that is going to interfere with digestion of food. A lot of time physicians will want patients to be on TPN because they need, like the question says, bowel rest. TPN is something that is given intravenously. You'll usually have something like a PICC line where the patient can have the TPN administered. You're not going to have TPN administered through an IV. Usually it's a tunneled PICC line that is placed in the patient where the patient can get TPN administered. Okay, so that's very important to understand because it's a tunneled PICC line that gets inserted into the patient in order for them to receive the TPN. The patient starts to experience shortness of breath and chest pain. What do we think is going on with this patient? So the options are, your client may be experiencing fluid overload. Your client may be experiencing an embolus. Your client may be hyperglycemic, or your client may have an inadvertent pneumothorax. Now, are all of these symptoms related to TPN? Yes, they are. That's where things get tricky. That's where people get confused because all of these symptoms are related to TPN, but all of these symptoms are related for different reasons. So we need to find the sign and symptom that is related to chest pain and dyspnea. Don't be confused that all of these things are related to TPN. We just need to hone down and focus on what is related to dyspnea and chest pain as someone is getting TPN, okay? So we have fluid overload, we have an embolus, we have hyperglycemia, we have a pneumothorax. And we know a pneumothorax is a collapsed lung. Hyperglycemia is an elevated blood sugar. An embolus is like a clot. And fluid overload, the patient just got too much fluid. Maybe the nurse put the rate wrong or the pharmacist didn't do the correct rate. Somebody didn't do the correct rate. Patient got too much fluid and now they have fluid overload. Those are what those options mean. Okay, so now, what I want you to know, if you don't know about TPN, what happens is TPN is a fluid that is critically put together by the pharmacy every single day. It is IV nutrition that your patient gets through a PICC line every 24 hours. So we have to get blood work done. The pharmacy receives the blood work. The blood work is specific to the patient's electrolytes. Electrolytes meaning your potassium, your sodium, your fat, your protein. All of these things are drawn in labs every day. The pharmacy receives it, and that's how they make that TPN for the patient every single day, specific to the needs of the patient. Okay? That bag is changed every 24 hours. That nurse has to go in and that nurse has to change that bag of TPN. Now, when the nurse is changing that bag of TPN and disconnecting the patient from that line of TPN, that patient, in between the time of the bag getting changed, there is a risk, is what we'll call. There is a risk of that patient actually getting what's called an air embolus. What happens is air can get into the line of the tubing and cause the patient to get an air embolus. Air gets into the line, gets into the patient can develop basically an air clot, right? So it's very important for one, the TPN tubing to be done as fast as possible. Two, if you're nervous about your patient maybe getting an air embolus, you may have this patient bear down or hone down so that it decreases the risk of getting an air embolus. Because remember that PICC line is usually right here in this location. So that's why that patient is at such a huge risk of developing some sort of a clot. Okay, so I pretty much gave you the answer, but I had to because I had to fully explain what a PICC line is, what happens with TPN, how the TPN is changed every day, and what the patient is at risk for. Okay, so it wouldn't be fluid overload, because fluid overload, of course, your patient will be short of breath. That's why they tried to trick you. But your patient is not going to tell you that they're having chest pain. You may listen to your patient's lung sounds and hear some crackles. The patient may be short of breath, or the patient may have some swelling or edema. It won't be hyperglycemia, though TPN can cause hyperglycemia. Usually if the patient's getting too much of TPN, or if the glycemic level is too high, meaning there's a lot of sugar or carbs in the TPN solution that was made and the patient gets too much of it, it can cause their blood sugar levels to increase and to elevate, making your patient hyperglycemic. That's not a symptom here. We're talking about chest pain and dyspnea. Okay, if your patient had an elevated blood sugar, maybe, or signs and symptoms related to hyperglycemia, maybe, but that's not the case. The case here is your patient's having chest pain and shortness of breath. That's all they're telling us. So fluid overload is not related to chest pain, could be related to dyspnea, but it has to be related to both. So fluid overload is not, okay? Hyperglycemia is not. They didn't say anything about an elevated blood sugar or signs and symptoms related to hyperglycemia. The next thing is a pneumothorax, which would be a collapsed lung. Didn't nobody say anything about listening to lung sounds and not being able to hear lung sounds being diminished. They said chest pain and shortness of breath. Chest pain and shortness of breath are directly related to embolus and emboli, because those two signs and symptoms, chest pain and shortness of breath, directly are related to an embolus. Fluid overload, dyspnea, but not chest pain. A pneumothorax, you may have some dyspnea, but you may not have chest pain. An embolus, directly. Shortness of breath, chest pain. Don't overthink it. Don't over-rationalize it. That's why answers are ended up wrong on the Nclex, because we're over-rationalizing and we're overthinking about things. Do not do that. We know with embolus, chest pain, shortness of breath, both of those things are related to an air embolus, okay? All right, so we have the last question. And the question is, which statement about total parenteral nutrition is true? What statement about TPN is true? Okay, so once again, one answer is correct, 3 answers are incorrect. So we're going to break these answers down and try to find the best answer, the correct answer. Option A is, clients are at a high risk for infection when they are getting TPN because they are immunocompromised. B is, clients are at a high risk for hyperglycemia when they are getting TPN because they are diabetic. C is, the client should perform the vasovagal maneuver when the nurse changes the TPN tubing. D is, the client should perform the vasovagal, I say vasovagal because I'm not about to get tripped up with that word. The client should perform the vasovagal maneuver when the nurse changes the TPN dressing. So 2 of these answers kind of look similar. Either the client should perform the vasovagal when you're changing the tubing, the client should perform the vasovagal when you're changing the TPN dressing. That kind of struck a nerve with me. So we're going to break these answers down, right? Okay, so let's start with A. Clients are at high risk for infection when they are getting TPN because they are immunocompromised. Ask yourself, is every patient who is receiving TPN immunocompromised? No. I may just have a bowel obstruction. I may just not be able to take fluid. I may not be able to eat or drink. I may have some sort of dysphagia. I may have failed a swallow eval. Something can have happened to where I just need to receive TPN because my bowels need to rest. So not every single patient who is going to get TPN is immunocompromised. That's not true. So A is not the answer. So we could throw that away. B says clients are at high risk for hyperglycemia when they're getting TPN because they are diabetic. Is every single patient who is going to get TPN going to be diabetic? No. Is every single patient who is getting TPN at risk for hyperglycemia? Yes. So they're trying to trick you. Not every patient is going to be at risk for hyperglycemia. Not every patient who is on TPN is going to be a diabetic. But the reason why every patient who is on TPN is at risk for hyperglycemia is because there's high amounts of dextrose in TPN, which makes every patient at risk for hyperglycemia, but every patient who gets TPN is not diabetic. So try to read and understand where they're trying to trick you. This option B says clients are at risk for hyperglycemia when they're getting TPN because they are diabetic. Everybody with diabetes is not going to be placed on TPN, but everybody who is on TPN is at risk for being hyperglycemic. That's where the trick is in this question. Okay, same thing with option A. Every patient is not immunocompromised, but every patient is at risk for an infection. Every patient is not a diabetic, but every patient is at risk for hyperglycemia. Okay, so that's how you know those answers are not correct, because they're telling you every patient is immunocompromised who's on TPN, and every patient is diabetic who's on TPN, and that's not true. C says the client should perform the vasovagal maneuver when the nurse changes the tubing. And then D says the client should perform the vasovagal maneuver when the nurse changes the TPN dressing. Okay, so one of these options are correct, and you really have to pinpoint where they're trying to trip you up or confuse you. So the client should perform the vasovagal maneuver when the nurse changes the TPN dressing. If you remember what I said before in the previous question, the patient is at risk for an embolus when I'm changing the tubing of the TPN, not the dressing, the tubing. Why? Because air can enter the tubing to cause an embolus, an air embolus. Not with the dressing. The dressing is literally, I am taking off the tape, cleaning the area, and reapplying the tape in an aseptic technique. So with the client having to do a vasovagal maneuver when I'm changing the dressing has nothing to do with anything, because air is not at risk for entering the tubing, because usually the patient's still going to be connected to the tubing while you're doing the dressing change. So think about it. If I'm doing a dressing change and it has to be an aseptic technique, what is my patient at risk for? Infection. I'm cleaning the dressing in an aseptic technique to decrease my patient from the risk of infection, not an air embolism. So the answer is C. The client should perform the vasovagal maneuver when the nurse changes the tubing, because air can enter the tubing and cause the embolus. Just like how the question before, when we said the embolus is the chest pain and a dyspnea, this option is you need to do a vasovagal maneuver when I'm changing the tubing, not the dressing. Okay? Hyperglycemia, because there's high levels of dextrose in TPN. So anybody, whether they're diabetic or not, are at risk for hyperglycemia. You're at risk for infection, not because you're immunocompromised like how A says, but you're at risk for infection because there's high levels of dextrose, one. So that puts the patient at risk with high levels of sugar concentration going through tubing. Through a tunneled catheter, you're at high risk for infection, as well as the fact that those areas need to be aseptically cleansed and cleaned according to a sterile technique, because those patients are at risk for infection. Those things can get wet, they can get dirty, they can harbor bacteria to cause the patient to get an infection. But in this instance, the only thing that is true is the client should perform the vasovagal maneuver when the tubing is being changed. And the reason is to avoid an embolus. The other ones, though they are true, the way that they're worded are completely wrong. All right, so that actually concludes our 5 questions that I did review. This one was a little long because we did have to do a lot of critical thinking as well as rationalization to pull the correct answer out. There are some things that you may not know that I do want you to make sure that you're taking notes on so that you have a better understanding, because questions like these can come to you, but they may come a different way. So if you understand what an opioid agonist is and an opioid antagonist is and what the side effects are, no matter what medication they throw or no matter what side effect or adverse effect they throw at you, you'll know the answer. Same thing with the TPN. If you understand that an infection happens when it's related to the cleaning of the dressing or the soiling of the dressing, you'll know the answer. If you understand that an embolus can happen with tubing changes, you'll understand the answer. If you understand that everyone is at risk for hyperglycemia, whether you're diabetic or not, because of high levels of dextrose in the TPN solution, you'll know the answer. Just know what the complications and side effects of TPN are and what they are related to. You'll be able to know the answer and pair it to where you can say, nah, yeah, this may be a side effect, but this patient population is not related to the side effect that you're saying. It's a general statement for all patients who are on TPN. And to basically know that TPN is usually given to your patients who have failure to thrive, your patients who are not eating enough and for them to maintain a healthy status, or your patients who have some bowel issues, whether it may be a bowel obstruction and the bowel needs to rest, but your patient still needs to receive nutrition. They may put those patients on TPN. So understanding who the patient population is, the reason for the TPN, who falls under that criteria of getting TPN, and what some side effects and adverse effects of TPN are will help you to better understand how to pair and understand what the correct answers are. Okay? So with that being said, I'm going to conclude here. This is my last Nclex review for now. I'm going to venture into the AANP review questions as well as tutoring. I'll do about 3. Since I did 3 for Nclex, I'll do 3 for AANP before I circle back around and come back to Nclex review questions. If you enjoyed this, just be on the lookout for Nclex review questions, and of course they'll circle back around. If you want one-on-one tutoring with me, please send me an email to drnursetutor@gmail.com and we can speak about those details when you do so. If not, just be on the lookout for more videos. I promise that I'll have them at least once or twice a week, so just be on the lookout for that. Okay, if you have any comments or questions in relation to the questions that I did go over, of course you'll have to send me an email at drnursetutor@gmail.com, and then we can further discuss that in detail as well. But the only thing that is free is what I offer on YouTube. Anything that you want to discuss in more detail or want more tutoring for, you will have to send me an email at drnursetutor. That is drnursetutor@gmail.com. You can also follow me if you want to know when I'm going to be doing more videos. You can follow me on Instagram. Same thing, Dr. Nurse Tutor on Instagram as well as TikTok, Dr. Nurse Tutor. So be on the lookout for more videos. They will be coming. And like I said, any comments or concerns, or if you want extra tutoring or detailed tutoring, just send me an email to drnursetutor@gmail.com. All right, I'll see you guys later. Happy tutoring, happy studying, and please, 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 if anything, critical thinking and rationalization. I cannot say that enough. All right, bye-bye.